Professor Hany Anwar from UK. Professor Hany, you are with us?
Yes, I'm with you. Can you hear me okay?
How are you, sir?
I'm very well, thank you. It's nice to be
It's very nice to see you, sir.
Today. It's nice to see you too. It's nice to see you all.
Thank you so much for accepting our invitation, sir.
It's my pleasure. It's my pleasure to talk to you today, and I hope it will be a useful talk.
Yeah, Professor Hany will speak about metastatic spinal cord compression, which is very interesting and very valuable talk. Thank you so much, sir.
Okay.
May you start, sir, please?
Yes, I'm going to share my screen now. Okay, let's hope that that works. Can you see
yes, it's quite obvious, sir.
Okay, so thank you very much for inviting me. My name is Hany Anwar. I am a spinal surgeon at the Royal National Orthopaedic Hospital in London, and my main interest is spinal tumors and also spinal deformity. But what we're talking about today is metastatic spine. So I've expanded the discussion to all of metastasis because I think metastatic disease affects oncology patients in, or spinal disease affects oncology patients in a lot of different ways. The pinnacle of that can be metastatic spinal cord compression, which is obviously a crucial topic, but actually we will come across these patients in many different contexts. And so we will also touch upon pathological fractures, the presentation of secondary spinal lesions, cancer of unknown primary when they present in the spine, which is a specific problem, especially if they have spinal cord compression when they present. Obviously, metastatic spinal cord compression, hematological malignancy, and some minimally invasive options that we are trialing in order to try to reduce the morbidity of spinal surgery in these patients. So we know that spinal pain, non-malignant spinal pain is very, very common. The cost to the UK economy per year because of people being off work with back pain is £12 billion, which is equivalent of about 240 billion Egyptian pounds. So a huge amount of money just because of people being off with pain in their back, despite the fact that they do not have any malignancy in their back. So it's a big problem. And it has a big differential diagnosis. We assume often that it's related to some muscular pain, posture, degenerative change, but actually there's a big surgical sieve which needs to be gone through when approaching these patients. And cancer is also a big problem. There's 2 million deaths per year in Europe with cancer. And, we compare that this year with about 100 to 150,000 coronavirus deaths. And the whole of Europe has been more or less shut down for that. So there's 2 million deaths per year, 4 million new cases per year. So, and many of these patients will have spinal metastasis before they die. 85% of people with prostate, breast, or lung cancer will have spinal metastasis at the time of their death. Mostly these are osteolytic, but 10% osteoblastic and 20% mixed. And 90% involve multiple levels. It's more often affecting the vertebral body, but it also affects the pedicles, the transverse process, the neural arch, and you will see metastasis in different places. So when we look at the number of people who are at the most common cancers, they are breast, lung, colorectal, and prostate. And these are all things that we will find in the spine commonly. And as we've said, most of them, or many of them, when they have advanced disease, they will have metastasis in their spine. So here is an unusual example, a 6-month-old boy with a history of back pain after an injury at PE. So PE is physical education, is just, and so it was assumed that his pain was due to an injury which was non-important. He had some physio and then he started missing school. He went to see an osteopath and a physiotherapist, eventually he saw a pediatrician. Even the pediatrician asked him to do some exercises and thought it was non-malignant, a non-malignant problem. or a non-tumor problem. Eventually, he saw a physiotherapist who wanted a second opinion. He was sent to us and we did an MRI scan, and you can see that there's a large lesion within the medullary cavity, and in fact, within the medulla and within the spinal cord. And also, when you examined him, he has clear weakness in both of his legs and long tract signs. And he's also suffering with night pain. So this turned out to be a large astrocytoma, which was extending more or less from T2 all the way down to the thoracolumbar junction, which was then excised via laminoplasty and then closed back up again. Unfortunately, he then developed quite a significant deformity in his spine, which we then had to fix. So we're on the orthopedic side. For an intramedullary tumor, of course, the neurosurgeons took that out at Great Ormond Street. Unfortunately, they didn't instrument the spine. So I think, you always have to be cautious of this kind of problem when dealing with a patient who has a large tumor. So most back pain is not pathological, and most spinal metastasis people don't have back pain. The most common metastases which affect the spine are lung, breast, prostate, kidney, and thyroid. We should remember that GI tumors are the most common, are much more common than thyroid, and so therefore we will see, despite the fact that only about let's say 15 to 20% of advanced GI tumors will metastasize to the spine versus 40 to 50% of advanced thyroid cancers, you will still, because of the volume of those tumors that you see, you will see more GI than thyroid. And hematological malignancies are very common. With cancer in the spine, a multidisciplinary approach is essential. We always involved appropriate oncologists, radiologists, etc. And I think in my practice, a tissue diagnosis is key because knowing what medical management and systemic treatment is available for that patient will affect your decisions with respect to surgical intervention. Our principles in metastatic spine is that we want to maintain neurological function, and we want to maintain alignment, and we want to avoid pain. These are our main objectives. And we've got two things that we can use in order to help to avoid deformity and instability: bracing and surgery. So, pathological fractures. We'll start with a case and we'll discuss the principles of how we think about this case. This is a 42-year-old lady. She has a breast primary, it's triple negative, so she doesn't have a great prognosis. She's got advanced metastatic disease. However, her disease has been reasonably stable on treatment. You can see that she has multiple metastases in her spine. And if you look at if we look at this central one, the issue with this is the translation. When you see translation like this, it has to mean that there's some kind of deficiency in the posterior elements as well as the anterior column. And if she has progressive disease and progressive pain, then this is definitely an unstable segment. This lady was presenting with no evidence of myelopathy or radiculopathy, but very extensive spinal metastasis. Now, this is a difficult situation because her prognosis, although the oncologists think it's more than 1 year, she still has advanced disease, and she also has multiple levels involved. What we look for in these kinds of cases is the minimum possible operation, which is going to allow her to be stable, but at the same time, reduce the morbidity so that she can get back to her systemic treatment as quickly as possible. So she has an unstable spine. In this case, we felt that we needed to stabilize her spine from essentially just below the cervicothoracic junction into the lumbar spine. And we used a combination of percutaneous fixation, percutaneous posterolateral vertebrectomy in order to excise this vertebra, and cement to augment infiltrated bodies at the top and the bottom. And the scoring system we'll come back to. So this was her fixation. Now, you see, it's difficult with a long percutaneous construct to make it look really beautiful. But I think, she had a quite quick recovery from this surgery, despite it being quite extensive. And she was back on her systemic treatment within about 3 or 4 weeks. So look for something which is going to give you as quick a recovery as possible, and don't be afraid of trying to treat people with extensive metastatic disease. She continued to be well for 4 years after this operation. Or, for example, this situation where we have a pathological fracture at the thoracolumbar junction. Again, what is the minimum possible fixation which will allow you to stabilize this fracture without and allow her to get back onto systemic treatment early? Because of the translation at the thoracolumbar junction, at the lumbosacral junction, it is difficult to get good fixation. But again, she was in her early 40s with metastatic breast cancer, in severe pain and not able to stand up. So in this case, we use navigation. If you navigate a fixation across the lumbosacral junction, as you know, the L5 pedicle screws, the trajectory for the screws is very lateral. So lateral to medial, and also quite steep in terms of its craniocaudal angulation. Whereas your iliac screws are extremely, are the opposite, medial to lateral. You'll find that the trajectory, if you want to do percutaneous iliac screws, the trajectory is actually more or less through a midline incision, that you can put a small incision into the midline and put screws into both ilium. And if you have towers, then you can connect that up to your L5 screws without having to make a big exposure. So I think that in patients who have limited prognosis, trying to be minimally invasive as much as you can, according to the equipment that you have available to you, is very important. So we fixed her like this, and she had an improvement in pain, and she went back on systemic treatment. Her prognosis, she only lived for another 6 months after this surgery. So, spending prolonged period of time in hospital is not something that you want to put these patients through just before they die. So always look at the minimum possible operation that will stabilize the spine and allow people to get back to their systemic treatment. And that's why understanding the biology of the tumor is going to give you a much better opportunity to treat them effectively. If it's a slow growing tumor which metastasized late and has lots of systemic options, then it's easy to be aggressive with your treatment because you know that it's a friendly tumor biologically. If it's an aggressive, quickly progressing tumor, you have to be very cautious about intervening. Really be sure that they have at least 6 months, preferably, before you intervene, especially if you're going to put instrumentation. And then intervene with something which will allow them to get back to their systemic treatment as quickly as possible. Metastatic spinal cord compression. So this is the second problem that we typically see in patients with metastatic spine. And this is really a premorbid state or a premortal state. Very few patients who are paralyzed because of metastatic spine will survive for that long if they have a complete cord lesion. We know for sure that decompressing patients with metastatic spinal cord compression improves their walking and gives a better restoration of ability to walk than radiotherapy alone in many cases. And we'll go into some detail about that as we go through. Here in the UK, we have guidelines for everything. And the National Institute of Clinical Excellence issues guidelines every few years on metastatic spinal cord compression. The latest guidelines that we have are that there needs to be a multidisciplinary discussion actually before really at diagnosis. So if a patient presents to A&E with a suspicion of MSCC, then they should have MRI scan really within 24 hours, but preferably as quickly as possible. And then a multidisciplinary discussion between the oncologist, the anesthesiologist, and the spinal surgeons about the best option in terms of treatment. They should be started on dexamethasone if they have confirmed spinal cord compression. And according to the guidelines, we do 8 milligrams twice daily. And their definitive treatment should then be within 24 hours of diagnosis. So essentially you have 48 hours, 24 hours to do the MRI and 24 hours to do the operation or radiotherapy. However, I would say that that's a long time. You know, really, if you have and we all know this, if you have somebody with progressive neurology, then you really want to give them definitive treatment as quickly as possible. But so we see 48 hours really the maximum time, but it depends on the presentation. Many of them will present, and I'm sure you have the same experience after a period of sometimes some weeks where they've had some weakness in their legs. They don't necessarily present acutely having been fine yesterday and suddenly profoundly weak today, although they sometimes do. So yes, definitive treatment within 24 hours. If they have a prognosis of more than 6 months, then decompression and stabilization is preferred in everything apart from hematological malignancies, really. So solid tumors, that is the preferred treatment. And then I would say that some of the things which are often ignored in the treatment of patients with metastatic spinal cord compression are, managing complications post-operatively. Many of them have issues with their bowel and bladder. There needs to be, a team who will deal with the various different complaints which they then have, whether it's because of their previous radiotherapy, whether it's because of their, bladder dysfunction, whether it's because of their bowels. They may need a spinal cord injury rehab team in order to be able to help them to get the maximum function. And often that rehab has to carry on for at least 2 to 3 months minimum after their initial treatment. And therefore that would overlap with them returning to radiotherapy or returning to systemic treatment, whatever that may be. So I think when you're trying to, and we're really quite lucky, most of the, in the UK, a lot of places don't have the facilities that we have here in this hospital, but we have a spinal cord injury unit, which is attached here. So they can get 2 to 3 months worth of rehabilitation following their decompression or following their radiotherapy, and then even go for radiotherapy or treatment with chemotherapy as an inpatient while still having rehabilitation. And the rehabilitation gives you probably at least 50 to 60% of your outcome. Your initial surgery will give you an improvement often, but in order to get the best result, actually rehabilitation is crucial. An investment in that is sadly here very lacking, but needs to be done in order to achieve the best results. We all know this paper, the original paper by Patchell in 2005 regarding a comparison between surgery alone, surgery and radiotherapy in the treatment of MSCC at a single level versus radiotherapy alone. And it showed that patients were able to maintain their mobility for longer, and there was a tendency for them to live longer with surgery and radiotherapy over those patients who were treated with radiotherapy alone. And this is really the basic evidence which has then been verified again and again in the literature over the last 15 years, demonstrating that surgery should be given to those patients who are able to benefit from it. We really extend those indications, however, and there's multiple scoring systems for this. I don't know what scoring systems you use. Many have been described, whether Tomita is probably one of the best known. Tokuhashi has also been modified to the modified Tokuhashi. If you look at the International Spine Study Group, you know, it seems that the ASA, just a simple ASA, is as good almost as at predicting outcome from surgery for MSCC as these other scoring systems. And the Karnofsky score, I use that quite a lot, because I think if they had a good performance, so that's a performance status. You know, what were they like before this all started? If they have a good performance status, then their chance of having a good outcome is much, much higher. If they have a bad performance status before presentation with MSCC, then the outcome is not likely to be that good. It cannot be better than they were before the surgery, before the MSCC began, and very unlikely that you will reach that level. So I look at performance status preoperatively as an important test. But I think what I would like to put across with respect to all the scoring systems is that they are all a snapshot in time. All of them were a study of the prognosis of patients with metastasis in their spine, according to the treatment that was available at the time that that paper was being done. And oncological management not only varies from country to country, but it also has been developing very fast over the last 15 years. And therefore, a prediction according to a modified Tokuhashi score of a prognosis of less than 6 months may well not be true today. And the easiest example of this is malignant melanoma. So malignant melanoma, which was stage 4, so if you have widespread metastasis, was previously considered to be for sure a prognosis of less than 6 months. Very unlikely that we would offer an operation to a patient with metastatic malignant melanoma to their spine, except in very specific circumstances, and even then with some caveats. Now, patients on immunotherapy with malignant melanoma are going into with stage 4 malignant melanoma are going into many years of survival, such that it's completely transformed their management. So if you were to score them on some of these older scoring systems, you'd not operate on any of them. And now you would strongly consider operating on them if they had a previous response to immunotherapy, or to be honest with you, if they were naive to immunotherapy, you might still consider it, as it's likely that they'll have a response if you have access to that. So that's why the multidisciplinary approach is key, because the oncologists in your hospital or the oncologists that you work with should have a much better grasp of the treatment options that are available to that patient, and be able to give you hopefully a more accurate prognosis, even if they use these scoring systems as well. And so we have a spine oncology MDT every week with the oncologist in order to review all of the decisions that we make, and try to get an audit process and some clinical governance with respect to how we make these decisions, because I think things are changing all the time for these patients. I think I would put it this way as well. If all of your patients that you decide to operate on survive for more than 1 year, then it may be that you're not being quite aggressive enough. I know that sounds like a strange thing to say, but then it means that there will be a small cohort of people that you may have been able to help who you were not able, you thought that they didn't have a good enough prognosis. It should be that you bring it as close as possible to the edge, so that you will get one wrong every 6 months or a year. And I think that's the way that that our numbers look like, as we adjust our criteria for surgery. I think you can never be absolutely perfect. And so you have to try to draw the line in a place where, 98% you get it right. I mean, of course, the objective is to get it right 100% of the time. That's your objective. But if you're never getting it wrong, then maybe your criteria or your threshold is a bit too high, because you may be able to lower it slightly and help a few more patients rather than sending them for radiotherapy. Radiotherapy is getting better and better, so maybe radiotherapy will be the standard treatment in the future. So here's a simple example: a 75-year-old with metastatic breast cancer. She has spinal cord compression. You can see that this, I think it's the T5 vertebrae, is completely vertebra plana with extruded material dorsally compressing the spinal cord. And she presented with profound weakness in both of her legs, with very rapid progression of her disease, of her neurology. And we took her to theatre. Now, we actually, she had very poor bone quality. We actually did this one all from the back. Now, it'd be very interesting in the question and answers to see how people approach this sort of problem. Obviously T5 is a difficult level to a certain extent to get to from the front. We often do a posterolateral vertebrectomy. So we take down a pedicle, sometimes both pedicles, in order to be able to get to the posterior aspect of the vertebral body. And then we can clear the anterior dura in that way, sometimes also with costotransversectomy, rather than opening it formally from the front. If you want to reconstruct from the front, your options are either to put a cage or to put a block of cement. In this particular case, she was so collapsed, we left the vertebra sitting, one vertebra sitting on the other. And we skipped one level because the pedicle was involved. So there's different options. Here's another example of a lady with breast cancer. Again, and I don't want to keep on going back to this point, but I think it's quite important. It's trying to minimize your surgery in patients who have metastatic cancer so that you can do the minimum thing that allows them to get back to their systemic treatment. And having the involvement, in this case, both of rheumatologists and oncologists is important. So you can see she's got spinal cord compression at C6, 2, 3, 4, 5, 6. She's got retropulsion of this vertebra. She's grossly unstable. She's also got involvement of the C3 vertebra and multiple other vertebrae. So planning an operation in this situation is difficult. You can see that C7 is also involved. Where do you start? Where do you stop? She's, again, a young lady, and she has breast cancer, which is treatable. So one of the things in cervical surgery especially is, I would reiterate what was said earlier about getting CTA. We try to get CTA in all of these patients in order to see the vertebral arteries, and in this particular case, it actually raised something which was interesting, because you can see here, this was on the left side, the vertebral artery actually enters the foramen transversarium at C5 rather than C6. So when you're doing your approach, you may find that the vertebral artery is actually sitting in front of the vertebra or sitting close to the tumor in your approach, rather than being safely tucked away in the foramen transversarium. So I think it's generally worth getting CTA, especially for some of these cases. We tried to minimize this, so we did a corpectomy at 2 levels. Again, what I wanted to show you with this is the usefulness of navigation as well, in that so you can see that the C7 vertebra was involved. C6 has to be removed. and you have to decompress the cord posteriorly. Rather than taking the whole of C6, I sat the, C7, I sat the cage onto the inferior end plate of C7. C3, I decided not to intervene with. And with navigation, you can put pedicle screws into C6, which I knew there was no vertebral artery in, C7, either side of the cage. Let me just see. Yeah, sorry. So you can see here that we have pedicle screws in C7, which have reasonable purchase on bone on either side of a cage, which is then sitting on the inferior end plate of C7. And then we put her in a collar and we treated with, she had a systemic treatment for her disease and she had denosumab. And you can see that even only at 3 months, there was quite significant restoration of the bone density or the bone quality at C3. And we followed her out now to 2 years. And you can see that at 2 years, actually, she had, with systemic treatment, good restoration of the bone quality throughout her cervical spine. She's more or less asymptomatic. So I think if you look at the initial MRI scan, you'd say, this is a very extensive surgery. You have to go from C1 or maybe occiput down into the thoracic spine. And that's why the multidisciplinary approach can be very useful. And in this case, I think navigation was useful too, to try to minimize your surgery and get them onto their systemic treatment early. So what are the things that we consider, whether we use cement or not? So kyphoplasty stabilization, decompression options, obviously anterior, posterior, posterolateral vertebrectomy, which we use a lot. You know, a lot of the techniques we use for primary tumors as well. But I think you need to have the full armamentarium of options in order to be able to decide how you're going to manage these cases. Just cancers of unknown primary are a particular problem when dealing with spine, because you will have presentations of tumors in the spine with patients who have not got a previous history of cancer. And sometimes they'll present with either radicular symptoms or cord compression, and therefore knowing how, and the majority of them will be metastasis, but knowing how to manage them is always a challenge. In this particular case, this is a 30-year-old man who presents with this large tumor affecting his L3 or L2 vertebra, and he has radicular pain, but nothing else really. And in this kind of situation, I would absolutely recommend getting a biopsy before doing anything else. He's young, it could be a primary tumor, and we know that if you treat primary tumors with en bloc resection, if they are stage 1, they have a far greater chance of survival than piecemeal resection or debulking or some intralesional procedure. So generally speaking, if it's not known what the tumor is, getting a biopsy and a tissue diagnosis prior to surgery is preferable. Many of the patients who will present with spinal cord compression with an unknown tumor, their neurology is either been progressing very slowly or is very mild or improves somewhat with steroids. And there is really an opportunity to get a biopsy. So I would say, if at all possible, before treating spinal cord compression with the tumor, which is not known what it is, a biopsy is really mandatory. And I have many examples of cases where the lesion was debulked and turned out to be a grade 3 chondrosarcoma, an osteosarcoma. And once a tumor is debulked in the canal and instrumented, it's of course going to be impossible to cure that case, because cure that patient, because the distribution of the cells will be throughout the instrumentation potentially. So you don't know where the seeding could be. So I would always stick to this. And you know, it's a great shame when a patient can have a higher chance of cure to have something like this. When we plan biopsy for cases which could be primary tumors, we plan it with surgeons and radiologists. The reason for that is obviously that we try to excise the biopsy tract at the same time as excising the tumor. So the skin and the muscle becomes part of the sample that we remove when we're doing our en-bloc resection. So the radiologists need to understand, obviously this tumor is far easier to biopsy if you do a lateral approach because the bulk of the tumor is laterally. But if you do that, it's very difficult to include that into your sample. So the starting with in the midline and going outwards is much easier to excise. What we do is we also tattoo the biopsy tract with methylene blue so that the tract can be excised at the time of surgery. And we try to make sure that we get that as part of the sample. So finally, if in this particular case it was a grade 2 chondrosarcoma, so in an en bloc resection, when we do en bloc resection, we then fix with carbon fiber. The carbon fiber fixation looks like this. It's difficult to see because it's radiolucent. You can see that the L2 vertebra and actually part of the L3 vertebra excised. At the top, we sat the cage onto L1 vertebra, but his fixation is carbon fiber, and that's so that he can go ahead with proton beam therapy afterwards. So giving these patients the best possible chance of cure means really how you manage them from the very beginning. And what I mean by that is getting a diagnosis before starting their treatment. So cancer unknown primary is an important area. So multidisciplinary approach, we have a system called 2-week waits, which basically means they need a diagnosis in 2 weeks. The biopsy should be done by at a sarcoma hospital by the surgeon who, a radiologist working with the surgeon who's actually going to perform the surgery to remove that tumor if necessary, and try to avoid surgery until you have a diagnosis and make a plan. Oligometastasis. So oligometastasis is a specific concept in spinal oncology, in oncology. And the idea of oligometastasis is that you have a state before cancer is widely metastatic, where you have a few metastases, but local ablative treatment to those metastases may still be curative. It's presumed that about 10% of people with 3 or less metastases might have this oligometastatic state. And if they have oligometastasis, that cure is still possible. And therefore, treatment for oligometastasis follows to a closer degree options for primaries. So potentially surgery with a resection margin, radiotherapy or ablative radiotherapy, or a combination of both. And separation surgery is definitely an interesting area in this. Stereotactic radiotherapy or ablative radiotherapy often causes fractures. I don't know if you have come across that frequently, but certainly patients treated for their renal cell tumors, if they're they've got a single metastasis with CyberKnife and so on, with very high doses of radiotherapy, I've seen many of them end up with post-treatment fractures, which can be very painful and difficult to treat. Also with carbon ion therapy, with proton beam therapy, I see a large number of patients who end up with fractures if they haven't had surgery beforehand. So they need to be looked after carefully, and sometimes it's worth even prophylactically doing kyphoplasty if they're looking very radiolucent after their stereotactic treatment. We do excise oligometastasis, but you have to consider this very carefully, because an en bloc resection is a very major surgery for patients with a high level of complications or a high potential for complications. And if they already have one metastasis, then I think there's still a high chance that they will develop metastasis elsewhere. This was a renal cell tumor in the pedicle. It was very isolated disease. She had very slow progression over about 15 years. I think she had a scapular metastasis and she had a scapulectomy, and then she had this vertebral metastasis. So we decided that we would excise it as well. And, she did well in the sense that after her partial vertebrectomy, she has not had any local recurrence. But I think now we're about 4 years down the line. She has a lung metastasis now. So I think the chance of getting cure with oligometastasis is speculative at the moment. And therefore I would be cautious. We have patients also who have oligoprogression. So they have widespread disease, but only one metastasis which is progressing. And we've done surgery for that as well. But these are interesting and rare circumstances, and I think they require discussion. This is, again, an unusual case, a thymoma. This patient had a thymoma about 15 years prior to the appearance of a metastasis from that in the spine. And so we did an en bloc resection of that. And within 18 months, he had further metastasis in his ileum. So, I mean, I think, yeah, I would be very cautious about going for radical surgery in oligometastasis. Hematological malignancies are common, and probably the most common thing that we see presenting with new disease and new pathological fractures in the spine. In the older population, mainly multiple myeloma, but we also see lymphoma. The good thing about that is that it's very well treated with systemic treatment. And a colleague of mine, Sean Malloy, has really led the myeloma service here and developed protocols which have been accepted nationally, and he really treats very few of them surgically. So hematological malignancy is always systemic, and chemoradiotherapy is very, very effective. It behaves completely different to solid tumors, and so we try to treat with systemic treatment and bracing. And there's only one exception to that. So here's an example. 46-year-old lady, new presentation. So this is an unknown tumor. She has quite severe spinal cord compression and a pathological fracture at the cervicothoracic junction, just the proximal thoracic spine, with disease which is involving the entire vertebra. This is a situation where I think it's very uncomfortable for anybody to treat this without surgery. We didn't have a diagnosis, but she had no neurological deficit. And we thought that this was likely to be myeloma based on her blood tests and the radiological appearances. So what we did in this case is, while she was on bed rest, we log rolled her into a lateral position and took an ultrasound guided biopsy of the spinous process. And the same day we had the diagnosis of myeloma. So we put her on steroids. Within 48 hours, she went from the picture on the left to the picture on the right. So the spinal canal was completely decompressed with steroids alone within 48 hours. We put her into a CTLSO brace and sent her for systemic treatment, and she didn't need any other spinal treatment. That level formed a decent amount of bone through the center and through in the periphery, such that she became pain-free. She remains neurologically normal 4 years on and without pain, and she didn't need surgery. So I think, I think if you're going to manage these patients without surgery, honestly, this is a very safe reason to do an operation. If there's doubt, I think it would be very reasonable to decompress and stabilize this young lady's spine to prevent neurological deficits. So I don't think that I should be misunderstood in terms of the way to manage this case. However, it is possible to manage these patients without surgery. And the advantage of doing that is that they get on to systemic treatment much quicker, and that is a better treatment for them in terms of their myeloma rather than having surgery, if it's possible. Fractures are a problem with myeloma. And what happens is you see the spine is loaded across the anterior column. So every time you get a fracture, the chance of you having a further fracture at the adjacent level becomes more, because the kyphosis means that the anterior column and the adjacent levels become is increased. So getting sequential fractures is highly likely. And therefore, if there's once you have a single fracture, I think you have to be very suspicious that this is going to be a progressive problem. And so we manage many of these patients with myeloma or particularly multiple myeloma in CTLSO braces or TLSO braces until they've completed their treatment and until they have some bone protection, either bisphosphonate or denosumab or something like this. Here is a patient who was not braced, and we can see he's already got some fractures. Oh, sorry. But wasn't in the unit, but there were multiple CTs of the chest, which allowed this reconstruction to be done. Sorry if I can play the video. And you can see that in what actually happened over time is this scapular fracture, along with further progression of the fractures within the thoracic spine. And once you get to this position, the kyphosis that's developed is much worse. And so our principles now really in terms of, I'll show you that again, in terms of trying to manage these patients, firstly, always check for a scapular fracture. If they have a scapular fracture, the chance of them progressing in terms of their thoracic kyphosis is much higher. Even if they don't, be suspicious. If they have one fracture, they're going to develop more fractures. And so if they're just starting their treatment, it's very reasonable to put them into a brace initially to try to prevent them developing a progressive kyphosis of their spine. It has a big impact on their quality of life after treatment, even if in the end their myeloma is well treated. The only exception really to conservative treatment in our practice is if there's bony involvement of the spinal canal related to a pathological fracture with myeloma. If there's a bony fragment in the canal causing spinal cord compression, or there's clear-cut instability, then steroids, systemic treatment, and bracing is not going to work. They need an operation. They need decompression, stabilization. And you can see quite clearly, this vacuum phenomenon on either side of the fracture gives you a clear idea that there's a lot of movement here. There's clearly bone coming backwards into the canal, and the size of the canal there is significantly reduced. This is our pathway. I can send it to everybody if you wish. That's not a problem at all. Finally, painful spinal metastasis. They're difficult to treat. We use painkillers, bracing, radiotherapy. Surgery is a very final resort, usually kyphoplasty. Opiates are bad. Try to avoid them if possible. They have complications. Having patients on high doses of opiates when they could otherwise be functional is a problem. So if there's a fracture which can be treated with kyphoplasty, it's a good idea. I'll show you this final, we're using ablation for our spinal metastasis as well now. So radiofrequency ablation is a very useful treatment for spinal metastasis. And we use the osteocool system. I have no disclosures to make with respect to osteocool. But there's other ways of doing it on the market. And we think that you can get a better result with respect to pain by using osteocool. So this is our pathway for treating painful spinal metastasis. And again, I think we can come back to that because I want to show you just one case, which is an interesting case. It's a patient with metastatic HCC, a 77-year-old with spinal cord compression. And they said he's got about a year prognosis. So here you can see, so the T10 level, He has a little bit of epidural disease. You can see that little bit of epidural disease in the canal. Yeah, if I run through that. At the T11 level, he has spinal cord compression and a metastasis which is affecting the vertebral body. Now, he was planned initially for separation surgery and then radiotherapy, but unfortunately, because of multiple medical complications, it was not possible. We changed the plan and we decided that we would do an ablation into the pedicles of that level. So you can see here, we put a thermocouple into the canal to measure the temperature when we heated the tumor. Then we put two probes into the pedicle, and we essentially did an ablation of both sides of the canal. Then he went on for radiotherapy, and he had radiotherapy both to T10 and T11. Now I'll show you T10. T10, 3 months post radiotherapy, it was not treated with ablation. You can see that he has epidural disease causing spinal cord encroachment and compression. If we come down to the level that was treated with the ablation, the canal is still okay. And in fact, better than it was previously. So it's a sort of control, the T10 was control. Both levels had the same radiotherapy. The radiotherapy alone level progressed. The level which was treated with ablation radiotherapy looks better. So we think this might be a useful treatment for patients where you don't want to do an operation, or for some reason you can't, or maybe it would be an option in the future for everyone. But we continue to do some work on this, and yeah, watch this space. I hope that we will have something to report regarding this. So in summary, spinal metastases are very common. They're often incidental. MSCC is an emergency. You should do surgery if they have a good prognosis, and that's a multidisciplinary approach. Oligometastasis, be very cautious about radical surgery. I'm not saying we would never do it, but be careful, because I think that most of the ones that we've done, and I've done a reasonably high number, have ended up with distant metastasis, even if they didn't get local recurrence. Yeah, the management of hematological malignancy is completely different from solid tumors. Thank you very much, and I'm available for questions.
Thank you so much, Professor Hany Anwar, for this very nice and comprehensive and interesting talk about spinal metastasis. Thank you so much, sir.
My pleasure. Thank you.
Thank you. Professor Mamdouh, you are with us?
Yeah, hello, I'm with you.
Hello.
Yes. Hello, Dr. Muhammad. Hello.
Yeah, yes, please. You are the moderator of this session, Professor Mamdouh.
Yes. Do you hear me, Dr. Muhammad?
Yeah, I hear you, sir. I hear
Hello?
you. Yes, I hear you.
Yes, sir. Yes, sir.
I can hear you.
At the first, I want to thank Professor Dr. Hany for his interesting and comprehensive talk.
Professor Mamdouh, there is a problem with your connection.
Full of descriptive cases.
Yeah.
And questions. I want a question for Dr. Hany. Thank you, Dr. Hany, for your nice presentation.
Welcome.
And very comprehensive and meticulous.
Dr. Mamdouh,
Do you hear
there's
me?
a problem with your connection, sir. Professor Ashraf, you are with us?
Do you hear me?
Professor Ashraf?
Hello. أيوة يا دكتور محمد.
You are with us, Professor Galal?
أيوة يا بيه معاك.
Okay.
I would like to thank Professor Hany Anwar from the Royal National Orthopaedic Hospital in Stanmore for this very nice talk. حقيقة يعني لينا الشرف الكبير. أنا آخر مرة رحت الرويال ناشونال دي كان أيام الكورس بتاع الFRCS زمان، أيام جرام أبلي. الله يرحمه بقى. This is a great pleasure for us to have you with us.
It's my pleasure to speak. Thank you very much for inviting me.
أنت يعني in your talk you have mentioned إن stereotactic techniques والجاما نايف والكلام ده will have a deleterious effect on the bone tissues. تعمل pathological correction subsequently.
Yes.
كان في ناس بيتكلموا على الكربون بروتون تريتمنت. نفس الكلام ينطبق عليها ولا يختلف؟
No, it's similar, I think. So carbon ion treatment, we don't have availability of it in the United Kingdom. So I only have 2 cases that I can use as examples. But actually, both of them have had problems with fractures after primary treatment with carbon ion therapy. So I have one who had chordoma in his sacrum. He had carbon ion treatment, 70 gray, only probably 9 months ago, and he has pathological fractures of his sacrum, which are now very painful and difficult to treat. And it's a young man in his 40s. We also have another chap who had carbon ion treatment again for chordoma about 4 years ago. And again, in the sacrum, he has fractures. So I only have 2 cases, but it seems to be a problem because they definitely do have fractures. In terms of proton beam, I haven't seen as much of a problem, but then there's not so many patients who are being treated just with primary proton therapy. Usually they're post-surgery. But I think essentially it's a problem with radiotherapy. If you give a very high dose of radiotherapy to bone, then it does have an impact. And I think if that's the primary treatment, you've got a risk of fracture, yes. It's not 100%, it's just a risk of fracture.
طبعا the cases you have mentioned الحقيقة and you have shown are very good cases which have shown good response. بالنسبة يعني for such poor countries في Middle East, invasive techniques for surgery احنا كنا زمان بنتعامل معاهم على اساس ان we decompress only the patients with neurological deficit. دلوقتي احنا داخلين في reconstructive techniques وكلام من هذا القبيل, which is quite demanding from the skill point of view for the surgeon. ومؤكد في morbidity في mortality معاها طبعا لما يكون في dangerous zones like the cervical spine or cervical dorsal junction, which is quite difficult to enter or to deal with surgically.
Yes.
أنا كان الابروتش بتاعي more conservative الحقيقة than aggressive, لأن أنا من old school, فما كانش أيامنا الكلام الجامد بتاع دلوقتي. The present techniques of pedicular screw fixation. البيديكولار screw fixation في السيرفيكال سباين بيبقى صعب طبعا unless you use navigation system أو robotic surgery. فأنا كنت بفضل اللاترال ماس سكرو الفيكسيشن of cervical spine.
Yeah. I mean,
لكن regards these techniques طبعا أنا actually أحييك على هذا الابروتشز وعلى هذه التكنيكس, ونشكرك شكرا كبيرا جدا على هذا يعني.
Professor Hany, there is just a question, please, from Dr. Ibrahim Amar. Do you use a scoring system to assess instability such as SINS score?
Yes. So what we should remember about this SINS score is that it was designed for oncologists as a communication device, so that the oncologist would have an idea of patients that they should refer because of instability and patients that they should not. That's why you have a scoring which says less than 7 is stable, more than 14 is unstable. And any spine surgeon could have told you without having any scoring system that the ones which are less than 7 were stable and the ones that were more than 13 were definitely unstable. It would be a very easy judgment. The ones which are difficult are the ones between 8 and 13, where it says potentially unstable. And that's the problem, that it still requires a spine surgeon to, if they're between 8 and 13, make a judgment as to whether or not that patient can be managed, say, for example, in a brace, or whether they need to have fixation, whether that needs to be anterior posterior. So yes, we use we use these scoring systems, we do use SINs, but I think the usefulness of it is for either, the early orthopedic spine trainee who is trying to get an idea of what they should be looking at, and the oncologists to refer patients, and also, of course, for documentation. So you can say, this is something that can be looked at later and can be audited and so on. So the answer is yes, but it has significant limitations.
Thank you, Professor Hani. Dr. Muhammad Ashhab.
Thank you so much, Professor Hany Anwar, for joining us tonight in this International Spine Day and for accepting our invitation. It was an honor to us, sir. Thank you so much.
It's really my pleasure, and thank you for inviting.
Thank you so much, sir. Now we come to the last talk and a very important presentation.